Yeah, we are live, ma'am. I think you can
Yeah,
start.
we are live, guys. Start.
Okay, so I'll just share my presentation. Thank you so much, Dr. Shilpa, Dr. Jay, for giving me this opportunity to be part of this for the first time. And today we are going to discuss about the basics of aneuploidy screening. So, well, we all know that the in the fetal aneuploidies, we know the commonest aneuploidies are trisomy 21 Down syndrome, trisomy 18 and 13. Now, first of all, the question that we should ask is, what is the need for screening methods for aneuploidy? Well, in 1970s and 80s, what we used to do is because we knew that with the increasing maternal age, the chances of Down syndrome increases, we used to offer diagnostic testing, putting in a needle, do amniocentesis and rule out Down syndrome. But then we realized that we are just picking up 30% of Down syndrome and we are missing out on 70% of Down syndromes with this. And there came the idea of screening tests for aneuploidy. So now what are the various screening tests? Now the thing is, in 2025, we have so many aneuploidy screening tests, the combined test, that is nuchal scan with double marker, quad marker, NIPT, even if we take the basics of it. So because we are spoiled with the choices for aneuploidy screening, and so there comes the confusion. When there are more than one test, we are confused about which test to offer to the patient and when. Now, before jumping on to the methods for aneuploidy screening, we must know about two basic things. One is what is a priori risk and what is the screening test. Now, remember, a priori risk is the risk that the fetus has of having common chromosomal problems, and that is related to maternal age and gestational age. Now, we know that with maternal age, the risk of common chromosomal problem, trisomy 21, 18, 13 increases, and it is seen more in the when the maternal age is more than 35. But we know that the major chunk of our population is below that. So screening for aneuploidy is universal and for every woman. Otherwise, we are going to miss on many of the Down syndrome. And as far as gestational age is concerned, the risk of these aneuploidies is highest at 12 weeks and will reduce by 40 weeks. Why? Because we know that some of the fetuses are going to die in utero because of these aneuploidies, and therefore the risk that we calculate is always at term. Okay, so we've understood about the a priori risk. Now, what actually we do in this screening process for aneuploidy? So we take the baseline risk or the age risk of the mother for that particular aneuploidy, and then we on to that we apply the likelihood ratio of a screening method, may it be nuchal scan with the various soft markers or the double marker, whichever test. And then after applying that likelihood ratio on that baseline, is the final risk that we get is called posterior risk or a patient specific risk. We come to know exactly what is the risk for aneuploidy for that particular fetus. So this is how we do in any screening test. Now, that was about the a priori risk and screening method. What does this screening test do? Basically, it helps us segregate the entire population into low risk and high risk category, right? We combine the age-related risk and the screening method, and the end result will tell us whether the patient is or the fetus is having the high risk or low risk for that particular aneuploidy. But remember, these are just screening tests and not diagnostic tests. Now, after this screening, whichever method you use, the high-risk population is then offered a diagnostic test like chorion villus sampling or amniocentesis depending upon the weeks of gestation, and the test depending upon the condition, the QFPCR, the karyotype, microarray, etc., etc. And we try and reach to the diagnosis, though it is not so simple as it appears in this slide. Now, so let's learn about the quickly about the various options available like combined test, quad marker, NIPT. So combined test or the first trimester screening is combination of nuchal scan and double marker, which is done between 11 to 13 weeks, 6 days. That is precisely when the CRL is between 45 and 84 millimeters. And the soft markers that we look at are the nuchal translucency, nasal bone, ductus venosus, and tricuspid flow. Now, before again jumping on to these markers, we must understand that a basic good CRL makes the basis for risk calculation for aneuploidy, because the nuchal translucency is a function of CRL, right? That means the nuchal translucency, which is high, making the fetus high risk at maybe 50 millimeters of CRL, may not make it high risk at 84 CRL. It's a function of CRL, and therefore there is CRL specific risk for the anti-centiles, which increases the risk for the fetus having aneuploidy. Now, this CRL has to be taken in a standard manner by a trained sonologist. The fetus has to occupy at least 75 to 80% of screen. It has to be in mid-set section, neutral position, crown and rump both visible. Then only you can consider that the CRL is standard and your risk calculation will be proper. Otherwise, if your CRL is not taken properly, entire risk calculation is going to be wrong. Similarly, the image which is to be taken for NT-NB has to be standard. The head and the upper thorax has to occupy 75% of the screen. The skin above the nasal bone, NB, nasal tape, square palate, and nuchal translucency, thin nuchal membrane, everything has to be seen well. Then only you can take that NT into account for risk calculation. So quality control is a must. Only a trained sonologist with standard image can do a proper risk calculation. So this is the NT-NB image. I'm not going to details of the ductus venosus and tricuspid flow, but these are the markers we take into account for risk calculation for aneuploidy. Now, one more marker which is important, which we always take into account, is the fetal heart rate. Why? Because trisomy 21 leads to mild tachycardia, trisomy 18 leads to mild bradycardia, but in trisomy 13, there'll be substantial tachycardia. Now, why is it important? Because in trisomy 18 and 13, you'll find there'll be increased NT. Both beta HCG and Pepe are on lower side. But when you look at the fetal heart rate, it will be significantly tachycardia in trisomy 13, and that's where it helps us in this calculation. That was about the soft markers on nuchal scan. Now, what about the biochemistry? I'm sure with combined tests, you are all doing the double marker test, which is free beta HCG and Pepe. Now, we must know the combinations of these two to try and look at whether the possibility of which chromosomal problem is high. So, for any euploid fetus, the MOMs for beta HCG and Pepe are 1. When these combinations are like the beta HCG is double, almost 2 MOM here, and Pepe is half, almost 0.5 MOM, this combination tells us that fetus is at higher risk for trisomy 21. But well, friends, not just trisomy 21, even in Turner, you will find that beta HCG is slightly higher, Pepe is slightly lower, and in diendric triploidy, beta HCG is very high and Pepe is low. So similar combination you find in many other conditions. Whereas in trisomy 18 and 13, you'll find that beta HCG and Pepe are low. So friends, whenever we have a look at our combined test or biochemistry, don't just jump onto the risk which is given by the lab. It is our duty to have a look at the MOMs of beta HCG and Pepe, because they itself will suggest possibility of which chromosomal abnormality is high, looking at the various combination. And this is the beauty of double marker over NIPT, because NIPT will not give you information about the other Turners, triploidy, etc., which this test can give. Now, what if the patient has missed the first trimester screening? Patient comes directly in the second trimester, 15, 16 weeks. Then you have anything to offer? Yes. We have quadruple marker, which is a combination of beta HCG, alpha fetoprotein, unconjugated estriol, and inhibin A. And let's have a look at the combination. So for Down syndrome, basically the alpha fetoprotein and unconjugated estriol are the fetal products which are reduced. And so as a compensatory mechanism, the placental products, that beta HCG and inhibin A, are increased. So when you find this combination of 4 hormones, you know that this fetus is at high risk for Down syndrome. Now comes a very, very important slide telling us about the sensitivity and false positive rate of each test. So as I said, we started with only maternal age more than 35. In that case, the sensitivity detection rate was only 30% because we used to miss 70%. When we combined this double marker with maternal age, the sensitivity improved to 65%, 5% false positive rate. When we take maternal age with nuchal translucency, sensitivity is 80% for 5% false positive rate. But look at the magic. When we combine the double marker with nuchal translucency, the combined test gives the sensitivity of 90% for 5% false positive rate. So this is the beauty, and this is done early on at 11 to 13 weeks, 6 days. So earlier, a good sensitivity. So this is a good screening test. Now, when we add further markers, nasal bone, ductus venosus, etc., the sensitivity improves to 94%. And the most important part is the false positive rate reduces to 3%. So we are reducing a number of invasives. And that's the beauty of adding other markers. Well, friend, I'm sure nobody is doing triple marker these days because the sensitivity is very, very low. It was the only biochemical test that was available 2 decades back. So we were using, but now we have quadruple marker in second trimester. So please, please never ever do. It's obsolete. Triple marker test is obsolete. And it's a quad test with better sensitivity of 80% with 5% false positive rate, which should be offered in the second trimester. One thing has to be very clear. There is nothing like only double marker. You can't just do risk calculation based on double marker. There has to be a primary screening test, that is nuchal scan, to which you add double marker. So it's a combined test which has a highest sensitivity of 90%. And there should be nothing like triple marker because it's obsolete now. Now, quickly we'll just have a look at how do you look at the nuchal scan report. When the report comes, it is a 3-page report and the risk is on the 3rd page. So what we usually do, just go to the 3rd page, look at the risk, whether it's high, low, what, and then counsel the patient. That's not the way we should look at the nuchal scan report. First thing is you should look at the date of the birth of patient because, as I said, the age of patient makes the baseline risk based on which we are going to calculate the posterior risk or the final risk. So if that is wrong or the age of the patient is wrong, entire risk calculation will be wrong. Then we look at the LMP, whether patient is sure of it. So we know about the proper gestational age. Then we look at the fetal heart rate, crown rump length, and nuchal translucency. Now here, as you can see, it's 4 millimeter. More than 3.5 is more than 99 centile for any CRL. So I know the risk is going to be higher because of this. So in this particular case, because the nuchal translucency was high, the double marker was not done, but we always look at the double marker and uterine artery PI, and then we look at the risk. Obviously, because the NT is more than 99 centile, it is showing high risk for trisomy 21, 18, 13 in this case. But in otherwise case, where the nuchal translucency is not so high, we always look at the beta HC and Pape MOMs. And as I said, if you look at the MOMs also, it will give you a lots of idea about which chromosomal abnormality is likely to be there in this fetus. And then looking at the uterine artery PI, which is also going to tell us about the risk calculation for preeclampsia, FGR, etc. And then you have a look at the risk calculation for trisomy 21, 18, 13, and preeclampsia, FGR, etc. Right? So never ever jump directly on this adjusted risk or final risk and counsel the patient. You have to look at everything. Which marker, whether the sonographic marker, the biochemistry, what has made the risk high in this particular patient, that we should be able to come to know from the report, and then we should counsel the patient based on the numbers. Okay. And then the final comments, of course, on the last page that you want to talk about. Just quickly, in 3 slides, I'm going to tell you about NIPT, that is non-invasive prenatal test. The better word is non-invasive prenatal screening or NIPS because it is still a screening test and not a diagnostic test. It tells you about circulating cell-free DNA of fetal origin, question mark. 3 to 13% of total cell-free maternal DNA is fetal origin, and it can be done after 10 weeks. Why did I put a question mark on fetal origin? Because we assume that these are fetal DNAs, but these are primarily coming from the apoptosis of cytotrophoblast of placenta. So these are placental DNA, but we assume that the chromosome of the placenta is representing the chromosome of the fetus. They are same. So it will, if there is any abnormality in this, it tells us that fetus is also having that aneuploidy. But not so in every case. In rare cases, it may differ, placental mosaicism, etc. So that is not the, I'm not going to go into details of it, but this is what basically, it's a test of assumption. Fetal fraction is very, very important in NIPT. It has to be at least more than 4%. If it is more than 8%, good. And the sensitivity and specificity, it is the best, NIPS is the best available screening test for trisomy 21 because the sensitivity is 99.2%, more than even the combined test, for the specificity of 99.8%. And for trisomy 18 and 13 also, it is 96 to 97%, good sensitivity for good specificity. Little lower for sex chromosome, 90%. And for again, the best part here for NIPT is that a false positive rate is less than 0.1%. What do I mean by this? When the false positive rate of a test, of a screening test for aneuploidy is less, my number of invasive is going to reduce. My number of amniocentesis is going to reduce. So whatever small risk of abortion is there is going to reduce. So that's the benefit of NIPT, a very low false positive rate with a very good sensitivity. But remember, it's a good test only for trisomy 21, 18, 13. It will not tell you about any other chromosomal problem or microdeletion, microduplication, because still we do not have robust data for that. So again, this has to be very, very clear, and it is not a diagnostic test. Even if it turns out to be positive, you have to offer amniocentesis. And the last slide. So based on our knowledge about the different tests, the sensitivity of each test, we must choose the right screening test at right time. One more important thing, at the end of screening process, there should be only one risk. So we have known the age risk. Once you apply the combined test, whatever risk comes at the end, that has to be the final risk based on which we counsel the patient, know the sensitivity of each test. Counseling, the pre-test and post-test counseling both are very important. And in pre-test counseling, you must tell that this is a screening test. And if you are found to be high risk, I'm going to offer you a diagnostic test, which will be CVS or amniocentesis, with which we'll be able to find out the chromosomal problem. Only if the patient is ready for that, we should offer the screening test. Otherwise, there is no point. And document what you offer and keep the option of no screening also open. If the patient says, I'm fine, even if it is Down syndrome, I'm okay, I'll continue, I don't want to know, that's fine. It's patient's take, it's patient's wish, but document that patient does not want any screening test. So I think in limited, whatever 12, 14 minutes I could mention about the basics of aneuploidy screening I've just discussed. And I think Dr. Shilpa, we can take on from here.
Yeah, Dr. Raghav, I mean,
Excellent lecture, ma'am. Summarized very well in 10-15 minutes all the basics of aneuploidy screening.
so
Thank
Dr. Raghav, in addition to whatever Madam told, so what is your like practice, or how do you take it forward, if at all, if like if the patient asks you which is the right screening method for me? I mean, do you individualize it, or do you have, because I know Dr. Jay has everything standardized in his hospital setup. So do you do it like routinely, like a copy paste thing for everybody? How do you do it?
So first of all, I would like to say that Down syndrome screening, aneuploidy screening should be offered to all the women. It should be a universal screening method for everyone.
Mhm.
Second, I would like to highlight that the first trimester scan should be done by a specialized person, because I want to highlight this fact that I get a lot of second opinions when the baby is structurally abnormal. So we have to keep in mind, if the baby is structurally normal, then only we offer screening tests. Suppose if I'm seeing increased NT or if I'm seeing some cardiac defect, I'm not going to offer screening tests to such babies. Directly we go for invasive fetal testing. We do the karyotype and microarray depending upon the anomaly we are dealing with. So first of all, make sure the scan is done by a good person. Always, you yourself can audit the images. Ma'am has shown beautiful pictures of NT and CRL, because the multiple of medians of your alpha fetoprotein, beta HCG, PAPA, PLGF are based on the CRL length. If the CRL is not taken properly, then the multiple of medians of those uh, biochemical markers will be affected, plus the anti-moms as well will be affected. So make sure whenever you come across your first trimester scan report, just look at the NT and the CRL image if it is taken properly or not.
Okay.
So in my practice, if a couple of points I would like to highlight that. Suppose in IVF practice, if you come across a donor egg, so in that scenario, we take the age of donor in consideration. For example, if we have taken a 25-year-old and we are doing IVF in a 38-year-old mother, so in this scenario, the age of donor egg donor will be considered, not the women who is carrying the pregnancy. These points need to be highlighted. Plus, after 35 or 38, according to FMF, 38 years is considered advanced maternal age. Till 38 years, if the I've done a good NT scan, baby is structurally normal, I offer them combined first trimester screening. That is NT, NB, HCG, and PAPE values. Plus, if there is a previous history of preeclampsia, now there is a new modality called preeclampsia screening. There are four factors in it. We take maternal factors into consideration. We take mean arterial pressure. We take placental growth factor, and we take mean uterine PI. So we take like we screen for Down syndrome, we screen for preeclampsia by taking maternal factors and biochemical factors in consideration. So if your preeclampsia risk comes high risk, then we offer 150 mg aspirin till 36 weeks.
We'll do this class, Dr. Raghav, next one,
Yeah,
like, preeclampsia screening in the first trimester. So,
yeah, yeah.
Bella madam, it was very nice. It was very crisp and very straightforward. So, over the next few months, I think we can have few more sessions where we can elaborate. So, I have written down the questions. So, each one is almost like a small class, like how we are having now. So, I will just put in the topics for the next few sessions. So I thank everyone who made time to join this. And I'm extremely grateful to Dr. Jay, Dr. Raghav, Dr. Bela Bhatt ma'am for joining this and taking this initiative to teach people. And I know a lot of people have these doubts because we get a number of messages to answer such queries.